For tonight, I know it's a little hard at the angle for some to see the screen, so if you do need to shuffle, feel free so that you can see a little better. So tonight we'll do a quick welcome. I'm going to give a short presentation summarizing interviews with several dozen doctors, CEOs, and other medical leaders in Humboldt County. And then we'll take a break to transition to the panel. I'm hearing a little feedback. Are you all hearing that? Okay, I see some nods and some head shaking. All right, might just be a little hot. I tend to be very, very loud on the mic. Thank you to Access Humboldt who are helping with the live stream as well as the sound and some other folks from the county, including IT, helping with this event today. So we'll have a panel discussion with some of the folks that their names are up here, and we'll have them on the slide as well in just a minute. And then we'll have a closing and opportunity to provide feedback. So the format tonight is not a town hall format. We will have an opportunity to ask questions, but it'll be electronically because we're incorporating people through the live stream as well. So we'll be including them, and I'll walk you through how we're going to do that. So we'll do that tonight, and it'll be kind of a listening and learning opportunity. So some acknowledgements. I know we have some of my colleagues from the Humboldt County Board of Supervisors here in the room. We have folks from Del Norte and Trinity counties watching on the live stream who couldn't be here tonight in person. Quite a lot of elected officials from local cities and our local community organizations, and then a lot of medical leaders in the room. So thank you so much to everyone who's here, and representatives. I should note that we also have representatives from our state leaders here. So they couldn't be here in person, but their staff are here today. So thank you for being here. The restrooms there's one single stall in the hallway here that's an accessible restroom, and then there's two more restrooms that are right by the front doors. And if there is an emergency in the room tonight, we will muster right outside the front doors in the big open space right in front of the building. And the live stream is occurring now. So again, thank you to Access Humboldt for facilitating that. And if you all need to stop me for any reason, you have carte blanche to do so. So you are the ultimate authority in the room. And so we'll go through a little bit about how we're going to ask questions and do live polling during the event in just a minute. So I'm Natalie Arroyo. I'm the current district supervisor for the County of Humboldt. I used to be a Eureka City Council member, and I'm also a Coast Guard veteran and reserve officer currently, and I lecture at Cal Poly Humboldt. So I wear a lot of hats in the community. I've worked with a lot of you while wearing those hats, and in all of these roles, I have to say the topic of healthcare provider access and the sense that we need to do more about recruitment and retention is out there in the community and gets expressed to me. So I've had a lot of opportunity for people to say, like, what are we going to do about this? And expect me to have the answers as an elected official. And as someone whose primary specialty and background is not healthcare, I really took this on because I wanted to understand what the issues are. And I started interviewing people and talking with them, trying to collate information to have a better sense of what the picture is at this moment in time. And then on top of that, my mom, who's here tonight and is doing very well health-wise, had a really big health scare as soon as she moved to Humboldt County. And we went through ICU, long hospital stay, inpatient rehab, really got a full tour as a family of the local, medical institutions, particularly that Providence offered. And our family had a, pretty good experience, all things told. And it was really eye-opening, once it wasn't that acute care and recovery period, to see where the gaps are and where the needs are. So it was really eye-opening for me as someone who gratefully haven't had a lot of experiences with that system. But it helped to illuminate what a lot of the constituents were telling me. So some of the ground rules tonight that I would suggest, really aiming to show respect to speakers and fellow attendees. We're all here because we want to hear what they have to say. If you need to have a side conversation or take a phone call, please do so outside. It is a very echoey building once we, are all in the space together. So please silence your cell phones. And then we're going to have some online live polling that I'll walk you through in the next couple of slides. So please participate to the extent you can. I realize it might not work for everybody, and we'll try to walk you through it, but participate as best you can. And there are very strong emotions on this topic. So this is something that people, come to me with their sort of greatest point of pain. And it's, I recognize that that's heavy and it's really challenging. So I'd ask that, please be patient with me and the participants tonight. So here's what we're going to do. And I didn't to take out your phones now. And we're going to use Mentimeter. And so this is an online live polling opportunity. Give me just a second because I have to switch gears. It's not going to do anything yet. Okay. So our first question using Mentimeter, so I will toggle back and forth. If you didn't get a chance to take a screenshot, to click on that QR code, I'm going to bring it back up. All right. So it may take a second, but this is a QR code. If you're not familiar with them, you point your camera's phone at that, and a link should pop up, and you should be able to click on that. So this is an audience engagement opportunity for me and you. Are you all seeing a question, those of you who are there? Yes. Okay. Now, the folks online should also be able to see this. And we'll have a question geared at them in just a moment. So anyone watching from home, watching the live stream on Channel 8 or on YouTube should also be able to participate with this. So I'll leave that QR code up for another few moments while you all answer that question. I'm dangerously close to the edge of the stage here. Hopefully this goes well. All right. So let's look at our results now. Nope. All right. We'll almost definitely be able to see it. A spinning moment. Technology is great when it works. Thank you. All right. Well, somewhere in that mix, we get to know who's here in the room with us. And in a way, this was a chance for you to get to use Mentimeter and for me to get to show you how it works. But it's giving us a little run for our money here. It did give you a flash of the results. That's awesome. All right. Well, great. Let me log back into that puppy. Don't mind me. I was, and we even test drove this to make sure it would work really well, but nothing quite like technology. All right. So we'll skip that. We'll go back to it in a minute. I like to think that so many people are participating via the live stream that it just broke the internet in here. So we'll go back to that in a little bit. So we'll have another opportunity to use that. Here's a little bit more about how to navigate back to Mentimeter. But we'll revisit that when we have another question to talk about. Gives us some troubleshooting to do. All right, so I want to talk about who I interviewed in this process. So far, since I did the Board of Supervisors presentation, I've interviewed more people. Right now we're at a total count of 57, and I looked through 6 documents that were pretty recent planning or strategy documents that were shared with me. So folks who are doctors, nurse practitioners, and physician's assistants, as well as other medical leaders, so CEOs, nurses, administrators, other experts who work around issues of recruitment and retention. And, it's interesting, I have a little note at the bottom about an enormous variety in responses. And people really had a high level of conviction about what they had to say. So everyone's having a very, I would say, kind of intense experience about what they believe is happening with recruitment and retention, and there was some variability. So I tried to really capture the things that were consistent. So today I'm going to cover some of the big changes and universal challenges that I learned about, really in my own words for you, and what is working, with recruitment and retention both, some of the unique local constraints we have to deal with, and then what the folks I was talking to said about what local government and the community can do to help. So to start with, there's really an issue nationwide with the a physician shortage. And I didn't know how bad the issue was until I started talking with people, because I had a perception stuck in my corner of the world behind the redwood curtain that it was unique to us. So unfortunately, this is some data that was compiled from a number of sources, but within about 10 years, we'll really be seeing a physician shortage in the neighborhood of 85,000 people. And that's not accounting for that's to preserve sort of what we have. That's not accounting for already underserved areas. So really to reach equity, it's more like 5 times that. So that's pretty daunting. And more than 40% of physicians in the United States are 55 or older. So we are looking at sort of a nationwide issue. And to kind of add to that, we're seeing a demographic cliff. So colleges are struggling to kind of recruit. We're seeing colleges close around the country. So institutions of higher education are already seeing this sort of demographic cliff that they've reached. And it really has to do with the decline in birth rates that happened around the 2006 to 2008 financial crisis. And they really haven't gone back up since. So communities that are seeing less of a demographic cliff are honestly communities where there's a little bit more immigration. So we're really seeing this kind of challenging workforce issue and a decline in college-bound students who are then kind of not going into medical fields. These shortages are much more pronounced in rural areas. And that said, quite a few people told me about how Humboldt enjoyed an abundance of medical providers that was sort of unique for a rural area for quite a long time. So compared to other rural areas, we were seeing quite a lot more providers. I'm not sure why, but people pointed to a lot of different reasons for that, but that this drew independent-minded people who wanted to have independent practices. So some waves of recent change that have really upended things. A lot of new medical record systems that came up in almost every interview that I did, that folks saw a wave of retirements when people were like, I just either can't afford to implement this or it's technically challenging, in a way that's not making it enjoyable for me to continue doing this work. The COVID pandemic, of course, caused some impacts that were pretty significant. And the new technology requirements, dealing with remote specialists, robotics, new systems, things like that. This big wave of retirements and conversions to part-time and quite a few closures of small practices. So the practice I go to, was bought by Open Door. And, I had gone there for many years. It was a small independent place. And, I love being an Open Door patient, but it went from being independent to being part of a larger network of clinics. So providers really are being assigned anywhere, a panel of anywhere between 800 and 2,000 patients, sometimes more, sometimes a little bit less, depending on sort of what their work needs are. But that's, something that I didn't realize as a provider myself. And there's a lot of interest in work-life balance and not really having the 80-plus hour work week that folks used to work. Also, a lot of younger providers are not in a single income household. And so, people are really wanting to have a different kind of work-life balance because of that as well. So some of the morale killers that were mentioned were really overwhelmingly, people mentioned this having less time with patients and more time with records, nearly a one-to-one 1 hour of patient care to 1 hour of record keeping, and noticing that people had a noticeably shorter fuse with their providers, taking out frustration about, what's missing in the medical system with the people they do get to see. A lot of folks mentioned the negative talk that people have about Humboldt as a whole, and that, of course, in any institution, leadership can make or break the morale. Some of the financial realities for individual healthcare providers, particularly ones who are recent graduates from med school or have recently finished their residency, are commonly leaving with more than $500,000 in debt. And I talked to people who've been in the community for decades who are also still paying off their medical loans. So significant loan debt that really isn't being made up for by a higher income. So physician loans being a product that used to be offered for folks in a lot of debt with a low down payment are pretty rare as a loan product today. And then those forgiveness and repayment tools really seem to be ever changing, and that information isn't always, it might be available at one institution with a team of folks who can support their providers in getting that information and then not available to others. So I asked who thrives here. And I should have mentioned to our panelists, if I get anything a little bit wrong, one of the questions is going to be, what did I get a little bit wrong? Or what do you want to add to? So please think about that while I'm speaking. So people who enjoy working solo in a really mission-driven environment and like to solve a large range of problems, who really got into it because they enjoy that fast-paced working environment. A lot of people lit up when I asked, like, you know, what they like about working here. And those mission-driven people really, really spoke about that of the puzzle. Folks who love the outdoor recreation opportunities and slower pace of life. Quite a few people mentioned this idea that people either love it or hate it. It's either a lifestyle they love or they just fundamentally do not like it. And there's, that it's tough to do something about that. And then people who have connections to folks here or who came here as a child on vacation, who have some kind of connection to place or people here. The current recruitment efforts really look like a special focus on bringing providers and their families to visit this place in person. I think maybe back in the day, there was less of that, and now there's an investment in bringing people here if they seem like they're a serious candidate, and coming here to actually visit the place and make sure it clicks for them. And not hiding the difficult aspects of life here, but showcasing the strengths. So wanting people to get a sense for, here are some of the challenges here as well before they commit. Bonuses and incentives, do exist for doctors, for nurse practitioners, for physician's assistants, and for dentists, but also folks in behavioral health and substance use counseling, and there's a special focus through Partnership Health on OBGYN in particular, and those incentives. And an effort to bring travelers or locums into longer term gigs by offering some flexibility. So, say like 2 weeks somewhere else, 2 weeks here, that kind of thing, or some other permutation thereof. And family medicine, NP, and dentistry residency programs exist locally. I think most people have heard about the family medicine residency and maybe didn't know about the other ones. So when I talk to the community, I don't hear that those are as well known or well understood. And then the recruitments really seem to be on an institution by institution basis. I've heard some stories about, we used to do it all together, and then we found that, it's just harder for the little guys to kind of attract the providers, and so now everyone's kind of doing their own thing. And there is, it was interesting to hear that Providence, has some Humboldt-specific recruitment folks that are separate from Napa and Sonoma, whereas that at one time was combined. So retention efforts, everyone talked about retention being a challenge. Some flexibility of schedules being offered. There are retention bonuses, particularly those offered through Partnership Health, but other institutions have them kind of mixed in with their programs as well for people with, in the case of Partnership, for 15 or more years of practice who are going to stay for more than an additional 3 years. Efforts to provide childcare, coordinate housing, other kinds of support, incorporating providers into organizational planning in the community. A lot of providers mentioned this, that they really wanted to be part of developing the vision for the future and kind of setting forth what the system is going to look like. So they spoke to that being a big retention effort and something that could really be meaningful for them, as well as, both, the clinic administrators and CEOs and folks who work within those systems really wanted to be part of a vision and wanted to sell people on a vision that they're trying to, make reality. All right, some key challenges that came up. Housing was front and center. I know that will likely not surprise y'all, but due to a lot of debt, some of the newer providers, this part did surprise me, that there are a lot of people seeking very modest homes or even townhomes, things that we don't really have a lot of in the community, condominiums or townhomes, something with a smaller footprint. So I, like many, had the impression that every doctor wants a mansion, and that did not come through in my interviews. It certainly came up at times that some people, want a big footprint, higher end home in a beautiful neighborhood, and that's great. But some people just wanted a modest house to live in because they were staying in hotels for a long time, or furnished rentals that didn't feel like a long-term commitment for them. So range of housing options really being key. People are in all different life stages and need to have some options. We know that throughout the community. Folks mentioned a borderline predatory environment of furnished rentals, thinking that that we've got a cash cow because we've got a medical provider here, not knowing kind of the bigger picture about what the financial circumstances might look like for folks. And then really seeing that some of the medical institutions are buying buildings, buying apartments and homes for their providers to at least have an initial place to land. So where those are available, they're kind of trying to snap them up. So insurance requirements, or reimbursement, could be its own whole separate lecture, and I don't think I did nearly enough interviews to understand the entire picture, so I'm going to skim this a bit, but it really helps to understand that provider face time drives the payments for everything else. That's something that I didn't fully understand, that if you don't have those providers that are MDs, DOs, NPs and PAs, acronym SOUP. If you don't have those doctors and nurse practitioners, advanced care practitioners who can charge for their time, then you're not going to get everything else, like all the therapists and all the additional supports that people need for their health. So that was really insightful to me. I don't know why it didn't click for me before, but maybe some of you are in that boat too. It really seemed like there were big differences in how institutions felt about their reimbursement pace and amount, which wasn't surprising to me, but really something that did surprise me was that Medi-Cal and Medicare really seem to pay less overall, but that reimbursement is pretty quick and pretty effective versus other forms of insurance. So as someone who has what is commonly called private pay insurance, non-Medi-Cal or Medicare, it is a bit of a challenge for our local providers and clinics. Lots of interest was expressed in exploring some other models like bundled payments, but there's some pros and cons to that. That's a whole other story. Incentives for wellness targets and meeting those are really key for some of our local institutions. So that means, getting enough people to get their breast exam, getting enough people to have this or that type of screening, and then having a bit of an incentive for having met those goals. That's a big part of the financial model for some of our local institutions. And then family medicine doctors are really the most versatile in that current system. So specialists, I'm sure many of us have struggled to get specialty care. It makes sense that the focus is on those sort of jack of all trades providers, but that does leave gaps, obviously. So connection to others and quite a few providers, especially people who are new to the community, mentioned that it was kind of hard to find their place, find their scene, find their people. A lot of us, including me, don't like to share what our favorite river spot is. How many of you like to share your favorite river spot with everybody? None. So, and at the same time, that's gatekeeping. That's kind of keeping people from getting to know what's really special and wonderful about our community. So I don't know what to do about that, but I'll leave it right there. Increasingly, providers are a more diverse group and looking for affinity groups and cultural connections. So that is really expected to grow. I heard from quite a few providers who identify as people of color that they were like, I just don't know where my scene is. I'm struggling to find a grocery store that carries food I want, or services that cater to my needs. And successes with social events and networking for young professionals. Big shout out to the Eureka Chamber. Several people mentioned some of the networking events and that those being really, really good, as well as culturally specific organizations like Black Humboldt. All right, mental and behavioral health resources, obviously another challenge and something we're working to address in a community. A lot of shortage of people taking referrals for private insurance to have mental health care. And a sense that was expressed that some crisis care aspects are improving and some better relationships with law enforcement, with the county, really, are kind of moving the needle, but that this is a huge challenge. Lots of folks expressed gratitude for crisis residential care and post-discharge support for people who are leaving, a hospital or leaving more acute care, and that we continue to need this desperately. Almost everyone mentioned that we have a large high-need population, and so it can be very overwhelming for the providers. Just feel like there just aren't enough resources. And I like the idea that if people are put off by seeing poor people in the community, they probably won't do well practicing here. I don't have a lot of direct quotes, but that was one that I thought, that sentiment came up quite a few times, but that was, I thought a well-expressed one. A catch-all of some other key themes. People, said they needed more help in their clinic setting, but also spoke about how skilled their team is. So just wanting, that was sort of a catch-22. We have a great team and we need more of it. And again, this idea that folks are not going to work 60, 80, 85 hours a week, that's a generational shift. Patients are really who breathe life into the day of the providers, and so the converse of shorter appointments and time with a lot of electronic paperwork is pretty hard for them too, just as it is for patients. There's a lot of really promising opportunities with AI technology and box management, some filling out of forms, things like that, but there's obviously a lot of caution around that as well. Childcare continue to be mentioned. And then even providers who briefly stay, provide this sense of immense value. And the, revolving door kind of negative narrative isn't helping because those folks might recruit other people or they may return themselves when they're at a different stage in their lives. And then this was something that I also hadn't really wrapped my mind around, was that when people go out of the area for specialty care, it has an impact on our local systems. So many of us, myself included, have gone out of the area when we need some kind of special care and we want to go to somewhere where we have heard that there's a great provider. And for people who have the privilege to do that, a lot of us are doing it. And where we can stay locally and utilize providers that exist, that's kind of helping that financial model work for the institutions, and it's also helping the providers themselves actually have that opportunity to see enough patients to really make that work. And it's tough because sometimes we just don't get that balance quite right. So some of the exciting things on the horizon, there's quite a few different programs to grow our own, really starting with K through 12 youth and pathways to local schools for pre-med, then mentoring, and then moving on to med school, especially for folks who are interested in coming back to Humboldt. There's some financial incentives there. There's specific programs for Indigenous doctors to go to school and come back and serve their community. Cal Poly Humboldt and College of the Redwoods have a lot of partnerships going on. They just announced additional facilities and additional programs, but quite a lot kind of incubating there. And then we have workforce development and medical business support through a lot of different institutions and a lot of burgeoning efforts. And these are great to see. I definitely heard a lot about them in my interviews and in other community conversations. And they're sort of they're starting to get some traction. So this is a moment where those are growing. And a shout out to those here who work with economic development and workforce development. And I see you and thank you for being here. So a continuing focus on the residency program, having recruitment bonuses and unique aspects of Humboldt. So things about us that are really selling points include being a climate refuge, having, for a small community, quite a few higher education institutions. And then it's a bit of a double-edged sword, but school choice for K through 12 was seen as an asset. And if people mention this, that I wanted to throw it in here. I know it can be challenging for those little districts, but it was seen as an asset. So local government ways to help. I'm going to try to pick up the pace just a little bit so we can get to our panel. So the ability to develop medical spaces by right by changing zoning and land use was something that several of my colleagues and I are going to work on. Definitely a lot of desire to support institutions with their advocacy efforts, particularly around insurance and building code. Exploring incentives for that construction, so working with the state to see if there are any incentive opportunities there, and then housing streamlining. So continuing to work on these zoning and land use issues was one of the first categories. Local government can also help by, continuing to support through our presence, some of these institutions and relationships by engaging with them. I can't tell you how many folks were delighted to have me come talk to them. So my fellow electeds, if we put ourselves out there, they will say, please, please, please come to our meeting. So investing in transportation systems, especially air travel, was key. And then really having a strategic focus on the economic development aspect of the medical sector. Those were huge. Looking upstream and really thinking about those long-term strategies that require a lot of commitment, public health, prevention, addressing childhood trauma, behavioral health care, all of those things really increase the capacity of our medical providers to help the people in need if there's other safety net programs in place. And then other collective efforts, a regional healthcare consortium. There are models for this in other places, and we do have our like local medical CEO group that meets, but formalizing a consortium that's broader than that could be helpful. Having some welcome aboard information that's shared throughout the community, particularly to connect people to cultural needs. Really conducting big picture thinking. A lot of folks said, we need to think differently about this. We need to get together and bring, bright minds together to think differently about this. And then, some folks expressed goals of becoming a medical tourism destination. Currently, we don't, necessarily have enough capacity for that, but it could be someday. And then really exploring solutions for partners of medical providers who need employment in the area to connect quickly and readily with those resources. The local community can help by, first of all, being nice to your providers. It seems silly to put this on there, but a lot of people talked about how their patients are, just have a shorter fuse than ever. So, taking a moment to reflect on that. Contributing to that positive online presence of Humboldt, specifically through leaving positive reviews of like local businesses and places and things you go and medical institutions. If you have a good experience, don't fake it, but if you have a good experience, get it out there in the community because our online presence is kind of rough, I'm here to tell you. So when people look up Humboldt, they're like, ooh. So supporting, a lot of those necessary social supports that I mentioned. And then encouraging the young people that we know to pursue medical careers. Those are huge. So I want to thank you for, taking the time to everyone there's a lot of people in this room who I interviewed, so thank you for taking the time to share your knowledge with me. I want to thank our panelists who are about to share their knowledge with us and interviewees and partners who shared documents with me. So I want to introduce our panelists. We are going to take minutes for a break, and I'm going to try to get the question asking thing back up so that it works properly. Our panelists are listed here. So we have Jennifer Heidman from Humboldt Senior Resource Center, Michael Kellerman from Providence and Redwood Memorial, Chris Myers from UIHS, United Indian Health Services, Matt Reese from Southern Humboldt Community Healthcare District, Doug Shaw from Mad River. Is Doug here? Oh, hi, Doug. Tori Starr from Open Door, Candy Stockton, who's our public health officer for the county, and Seth Whitmer for Redwoods Rural. I know that's not every institution represented, but it's a pretty good swath, and I'm looking forward to hearing from them. So we're going to give it a break, and I'm going to try one more time. You know what? I'm going to have to hide what I'm doing here. I apologize to Access Humboldt for making it weird. I just want to hide the behind the curtain part really quick. I have to use humor for the occasion. All right. So we skipped some of the fun time questions, which were mostly meant to get you familiar with this thing called Mentimeter. And now it's back up. So I'm going to show this QR code again. We're going to try it one more time. This is for the people on the live stream. So there should be a question up about what questions you have for our presenters. Now, we're going to take a short break, and that means that if you have a question about how to use this platform, you could ask your neighbor. You could ask someone sitting close to you. So if this is flummoxing you, please feel free to turn to someone near you, see if they can help you get your question in here. So the prompt is to ask one question, but you can ask more than one. So if you really have a lot in your back pocket, go ahead. And if you want to ask a question on behalf of your neighbor because they're having some technical challenges, you can also help them with that. Oh, sorry. There we go. Nailed it. All right, so we're going to take about 10 minutes. Please get your questions in. We're going to have some folks helping to get them to me as the moderator, and we'll invite our panelists to come up on the stage. Thank you. All right, so last call on this. You can still continue to contribute questions as you're hearing them, but I'm going to take this slide away, so you're going to potentially need that. You can take a quick picture if you need it. All right. And that is no more. Okay. Thank you so much for being here. I'm sorry to block Jennifer for y'all on this side, but I have to get on the stage to be in the live stream. All right, so our initial questions. So we have some initial questions as the audience questions are continuing to come in. So our first one is really just asking you to share a very brief introduction of yourself and your role and what you love about your job so people can get to know you a little bit. So I'll start with Jennifer and then we'll just kind of pass it down.
Hi, I'm Jennifer Heidman, and my current role, and it's for the last 10 years, has been medical director of the Redwood Coast PACE program, which is a program of the Humboldt Senior Resource Center. I've been in Humboldt County since I finished my residency at UCSF about 23 years ago. So I came right up here. And so I really have a good historical view, at least for the last 23 years, of how much things have changed. And, you know, the reason I came up here was because there's just this fabulous medical community, a beautiful community in general. And it's a very interesting and challenging place to practice medicine. And so I'm, trying to remain hopeful that we can bring that back. And really excited that so many people came out tonight. And so I guess what I love about my job is the community.
Hi, I'm Michael Kellerman. I'm the Chief Executive for Providence in Humboldt. I've been here officially a year as of January 22nd of this year. And what do I like about my job? Shouldn't have to think about that, huh? Honestly, a couple things. One, the people that I work with, when you get to go onto the floors and you actually go and meet some of the patients and you see the teams that work with them, there's something that's very inspiring about that. And then the second piece that I love about my job is, in a community like this, at least, it does feel like you can actually make a measurable difference. And I like that. I like the fact that when we start to do something, we can see it, we can feel it. And that's unique.
Hi, I'm Chris Myers. I'm a general surgeon by training, came out here 6 years ago or so to do bread and butter general surgery. Was recruited from UIHS into a more administrative role, and that's where I am now, Chief Clinical Officer at UIHS. What I love about my job, kind of multiple fold. I think the organization I enjoy working at because we serve a unique population with unique needs, and we're able to do some things that maybe other organizations can't. And some of them are a little jealous of us, I think, and that's okay. On a personal basis, I enjoy being one of the people that can provide support to the clinicians that are doing the really hard work, and lucky enough to be in a position to actually make some changes to help support them.
Yeah, so Matt Reese, Soham Health, Southern Humboldt Community Healthcare District. What I like about my job is it's a challenge. There's something new every day. And unlike these guys, I'm not so jealous because I don't have to work for a system. I can make changes quickly. We can do things rapidly. We don't have to go up the chain of command like Doug here. We have similar organizations that we don't have anybody overseeing us, so we're a little more nimble, and we can do the things that we want to do that we think really will affect the community, and we can make changes quicker, and we can do the things that we feel are best for the community. And so we've really tried to serve our community well, and it's been it's something I've really enjoyed.
Doug Shaw, CEO, Mad River Community Hospital. I am the chain of command at Mad River Hospital. Matt knows that, but I admire Matt for everything he can do in his little facility down there in Soham. They're going to build a new hospital. Very proud of you. Done a lot of great things. I like healthcare because I love taking care of people. I've taken care of people who are passing away. I've taken care of people when they're alcoholic. I have been a caregiver, and that's my pronouns. I'm a caregiver, and I'm proud of it. I've done it all my life. I just happen to fit into that. I don't know why. And now that I get to be in a position where I have healthcare in my blood, I like to help, and I'm in a position to do it. And that's the best part of all, and make a difference.
I'm Tori Starr. I'm the CEO of Open Door Community Health Centers. I want to start by saying thanks, Natalie, for actually opening up what I hope will be an ongoing dialogue with the community, because healthcare is really about the community. And the only way we're going to be successful is working together around that. And it's been fun to work with the folks around this table and on this team here. So I am a nurse, it's hard to believe, for over 40 years now. I graduated from the original Humboldt State Nursing School before it was reinvented again. Hi, Barbara. It's a wonderful opportunity here. I'm one of those people, you did a great job of capturing things, Natalie. It was really wonderful. I'm one of those folks that came up here and loved it, right? Like I didn't want to ever be anywhere else. So, and I had the good fortune of being able to stay here and do a variety of things in healthcare. So I've been doing leadership for over 30 years now. And I had the opportunity to come back. It's hard to believe 5 years now to come back and take over the responsibility for Open Door. And the reason I did that was because it was such a opportunity to take care of the community and really try to create some enduring and sustainable systems so that the place that I'm going to retire in and die in, that we can have a system that works well. And I love being able to work with people, as Michael said, because fundamentally healthcare is about people taking care of other people. And our job as leaders is to take care of those folks that take care of others. So thanks.
Hi, I'm Candy Stockton. I am a family medicine doctor with a subspecialty in addiction medicine. And I have worked in rural Northern California, parts of it here and in Shasta County for almost 20 years now. I am a good example of what happens when you train up members of your own community. So I am a 5th generation resident of Humboldt County and a 2nd generation physician from Humboldt County. So I have watched, like many of my colleagues have referenced, the changes, the differences in the way the healthcare system and community looks now compared to 30 or 40 years ago. But what do I love about my job? I left the practice of clinical medicine 3 years ago now when I transitioned into the health officer role. And I did that because I found as a practicing clinician, one of the things that I was struggling with and that my patients were struggling with is there were so many needs that were impacting our ability to provide healthcare. So you can't just write a prescription that takes care of the fact that takes care of somebody's diabetes when they're unhoused or they don't have a budget for food or any of these types of things. And so I really jumped at the opportunity to work with our community on the upstream factors that are affecting people in our community and to really serve as kind of a liaison between what those patient care needs are on the front line where I spent 20 years of my career and what our policies and systems look like that help support those services. I also love the fact that this is a small community. As you can tell, just watching us interact up here, we almost all know each other. Even if you're fairly new to the area, you've kind of been wrapped in. And so it is possible to do things here that you can't do in a larger community because I can call up Tori and be like, hey, remember that fellowship program that we both did and how they talked about this thing? Could we talk about how we join this process? Or, when I called Jennifer with an issue, like they not only take my phone calls, but most of the time they pick up the phone call from me knowing who it is because they recognize my number. So.
Thank you. Well, Natalie, I first want to just say thank you for your service in the Coast Guard. I'm a disabled veteran of the United States Air Force. I was born in Tucson, Arizona, so I am not a native. I've lived all over the country. My background is I've been an administrator in long-term care of critical access hospitals and other federally qualified health centers, which is what Redwood's role is. I've also worked at Department of Energy sites providing healthcare services. And right now, I like to say that that I help people thrive. My job is a culture leader, and I help my teams succeed in being able to do what they do best, and that's take care of patients and overcome obstacles that get in the way of doing that. So I'm excited to be here. I'm not from the area, but I've absolutely loved being here. Trying to get my family out here from Kansas is where we're moving from. So hopefully in the next few weeks we'll all be out here. So thank you.
Okay. I'm going to keep a mic for myself, but we do have one per table here. Seems like y'all are just doing a great job of passing it down. So let us start with Seth on the next one and just work our way backwards. So you may have to press the on button on the mic there. And I'm going to wrap in one of the audience questions into the next question. So the next question I was going to ask was, where do you recruit and how do you go about it? But I'll add in the audience part, which is what is one of the most successful strategies for doing that in your mind?
Yeah, I think where we recruit from is everywhere, and how do we go about it is everything. And I think the best way in which we get those results is by trying to find people who are willing to come out and show them what we are like, and having them meet all of our team, and making sure that they see what our culture is. Again, like I said, I help lead culture, and to me that is extremely important in being able to help prospective providers understand what it would be like if they came and joined our organization. Because when we talk about retention, one of the big factors that leads to providers leaving is because they feel like they don't belong, they feel frustrated, they feel like they're not getting help. But if they really meld with the culture and with the team, they're a lot less likely to leave. And so I think having that really well established when they come in and look at things, I think also making sure they bring out their significant others is also extremely important, so that there's no shock there, because I have seen that in the past, and so it's important to make sure that everyone sees what it's like. So I'll pass it on.
So in my current role, I don't recruit directly for hiring other clinicians, but this is my home. This is where my children will have their children, and also where I will grow old and retire and die. And I'd like to have health care for those phases. So I work with a number of state and national associations where I train and mentor people in addiction training and in primary care settings. And I'm always talking with them and looking for ones who seem interested in mission-driven medicine. I found Natalie's statement. She didn't get this from me. I didn't mention it. But I actually, before I had kids, always thought that I would spend my career in Doctors Without Borders. So that is exactly representative of at least some of us. And so I'm always looking for those and figuring out who I can introduce them to. I have more than once called Providence or called Open Door and said, hey, I don't know how serious they are, but I've got somebody I met so-and-so. I'm giving them your contact information. And so always try that network, because personal relationships are what keep people here, and often they are what bring people here.
Similar to what Seth said, we recruit from all over, but mostly we try to pay attention to being here. The reason we started the family medicine residency program with Providence was the data is very strong to show that if people train in a certain community and get to know what that community's like and what the delivery system's like and build relationships, they're likely to stay here. So it wasn't easy standing up the residency. It's still a lot of work on an ongoing basis because it involves people from that standpoint. So we actually have a recruitment team. If you look at it, it's actually 6 people when you include myself and our chief medical officer. So we're always working, and we're recruiting not only just for physicians or nurse practitioners, but behavioral health folks and a lot of different things. And one of the keys that I do is my wife and I interview people the last, and we interview the provider and their family, because we're trying to recruit people for their entire career. We don't want people just to come here to pay off their student loans. We want them to be integrated into the community and to stay here. And so we're going to talk a bit about that later tonight. And Natalie, one of the things you said, what was different on here, what we find is that people want to practice in a team, not solo, because primary care is really hard these days. And the only way to make it work is with a team. And so I would also say, even though providers are super important, it does us no good to recruit a doctor if we don't have a well-trained medical assistant to support them. So the conversation should be expanded beyond just what our providers are.
Similar, we have a team for recruiting. We send a questionnaire to our potential candidates and tell them where we are. And do they know that? And that we're not right above San Francisco. We're 5 hours above San Francisco. Everybody thinks Northern California is San Francisco. And then next to that is Arcata isn't Arcadia. That's always a trip for people. You mean no, yes, really, you're not going to make it. So, and we look for people with a fit. And of course, the outdoors, as was demonstrated on the wall. All of those sort of things are important. Most of all, they have to embrace what they think is going to be terrible weather, and we haven't talked to enough people to say it changes. It's fine. It's better than Seattle. It's better than LA. It's really, really, really nice. It hasn't been hard to recruit until the last 10 years. We always just sold the place. We always sold Humboldt County and everything that's going on here. University, community, agriculture, next door, all those sort of things, but it's just getting harder.
So one of the most successful ways I've found of recruiting is using my doctors to recruit. So about 10 days ago, my doctor said, hey, we got this new guy coming on, and I hadn't even met him. We hadn't had an interview or anything. And I said, hey, wait just a minute. My admin team wants to have an interview with this person before they come on. But using our own providers is an excellent way to recruit. We've also used recruiters and done just about anything we can to bring new physicians on. We just had a new one start today, and I'll tell you a little story later on about what happened to her today on her way up here. So anyway, but yeah, it's exciting to have new people coming on and having our providers actually out there contacting the people that they know, bringing them on board.
I'm not sure how much more I have to add. We utilize all the normal recruitment tactics, all the online resources. We post in New England Journal of Medicine, JAMA, American Academy of Family Practice, kind of wherever we can. In addition, we pay recruiters to find us providers, a lot of word of mouth. I'm not sure any one modality is more better than others. It's just kind of a hit or miss. I do want to share a miss, though, that kind of speaks to, Tori mentioned earlier, that it really takes the full community to support the medical system. So we had a provider that planned to move out here with his family and set down roots. He'd been doing locums for years, and his family was at the position they wanted to live somewhere more permanently. About 30 days before he was supposed to arrive, he mentioned that his 16-year-old son wanted to become a pilot. So are there resources for him to become a pilot? I reassured them, absolutely. We've got those. We've got airports. We've got a simulator at Cal Poly. We can certainly make that work. I couldn't find anybody that would be an instructor for this 16-year-old. So it even takes private instructors, pilot instructors, to recruit providers.
I'm going to echo a lot of what you heard. Recruitment firms, partnering at career fairs, connecting with residency programs, fellowship programs. Some of the differentiators that maybe we're starting to employ now is, so our family residency program that we've partnered with Open Door on, this is more of a long-term tactic, but we built relationships with medical schools. So Idaho College of Osteopathic Medicine, the acronym is ICOM. Just last year, we signed an agreement with them where their 3rd and 4th year students get to rotate through our residency and through our hospitals, and it gives them exposure to our community. And from there, they're going to go into their residency. But the hope is that these individuals may want to come back. And we've met a few people that have either changed their direction. One of them says he wants to be a neurosurgeon because he connected with one of our neurosurgeons. He loves this area. How do I get back here? You touched on loan forgiveness. We've launched it's a philanthropic campaign known as Destination Humboldt, where we try to utilize certain dollars for loan forgiveness. There's some caps there, so you talk about government side. There's hospitals are under a lot of regulatory control. So we can't give a physician above a certain dollar amount for loan forgiveness because the government will say that we're incentivizing that physician for referrals, when in fact we're just trying to help them establish into a community that needs that help. The other thing that we've done is to help build, you mentioned about the medical schools, so through ICOM, Cal Poly, so we talk about acting as a community, Cal Poly actually signed an agreement with this medical school. So if their students at Cal Poly meet a specific criteria, they will get an interview. And that's kind of unheard of. And so that's something that we'll see how that matriculates over the next few years and what will come of that.
So a couple things. I echo what everyone here said. I do want people to know that doctors and nurse practitioners and PAs really hate being called providers. And I think that it kind of speaks to the bigger issue of like, what is a healer? Like, what role do we have in the life of our community? And that's a thing that I've really seen change over the years, is you've sort of become a literal provider of a service instead of someone who actually might see someone, like a family practitioner might see someone from birth to death. And, the people that we care for are the people we run into at the farmer's market or our kids' games or whatever. So I just think as we're talking to people about this, we should remember that, the humans that go into healthcare really doing it because they want to connect with other human beings as healers. And so if we could eliminate the use of the word provider, that would make me so happy. It's never going to happen. But anyway, in terms of recruitment, I work for a very small agency, and I can tell you that people want to work for us because we do high intensity, very personalized, low productivity care, which I think every human should have. And our system as a whole is geared toward getting doctors, nurses, everyone to see as many people as they can in a day. That's how our healthcare system is set up. So I think that's the other bigger thing we need to look at is the system really made for someone to do their best, to be their best self, their best professional self and their best human self. In terms of my, journey up here, it really is word of mouth. I have a sister-in-law who's a psychiatrist who worked up here and told us about this area. And then when I met the doctors up here, I was blown away by their expertise and their well-rounded selves. And that, for me, then you were mentioning river, like the best swimming holes. Well, in the first month, I think, of being up here, I got invited to go out to the Lost Coast for mussel hunting, and with some old retired doctors, some current doctors, and some other community members. And that was it for me. That was like, oh, I want to stay here forever. Despite all of the challenges, and there are challenges here. I've had personal challenges raising my children here, serious ones. But there is a special thing about this community. And I think that's really what we need to, quote unquote, sell to people. And we have to continue to create it as well, though. So that's my 2 cents.
Awesome. Well, for the next one, let's, just for mixing it up sake, let's start with Matt. You have the mic pretty close to you. You might have to turn it on. And yeah, thank you for adding so much nuance there. What are the points of pain in your organization that you want people to understand? What are the challenges that you wish people understood better? or those, I'm sure there are a long list of them.
We don't have any in our organization.
None.
No.
You're really
So-
selling So-Hum Health.
So, one of the challenges with healthcare, as you all know, we've talked about it, Medicare, Medi-Cal, financing and payment structures and other things are kind of ridiculous. I get when a Medi-Cal person comes in my ER, I get about 15% of my cost. That's my cost. That's not my charges. I get 15% of my cost. And I've got a state report that I file, the 951 that I file with the state every year. So the state's well aware that they're paying me 15% of my costs. They haven't given hospitals an increase in over 13 years. And they expect us to meet the seismic requirements. They expect us to meet the new minimum wage for healthcare workers, $25 an hour. They expect all these things to just happen magically without any reimbursement to us. And so that's a real struggle that we have. Now, I have some programs as a district hospital where I just gave the state $4 million back in December, and they're drawing down the federal money. So here in a few weeks, I'll get a check for $10 or $11 million. I'm not even sure how much I'm going to get, but I know I'm going to get a good return on my money. But what it is I'm putting up the state's portion of what they could be paying me to draw down the federal dollars that I deserve that are eligible for me. But I'm having to put up this money to get this other money, and to make it even worse, I'm paying the $4 million I put up was for money that they didn't pay me in 2023, and my growth has been exponential over the last little while. We tripled our gross revenue in the last 5 years, and so when I'm getting 23 reimbursement, it's really killing me, and especially when they're not paying me cost. So those are some of the struggles that we have. And we have to figure out how to navigate all these things. And I've got a great staff. They've brought in some grants. We're doing a new clinical trial with UCLA, and we're doing all these things to bring in some additional money to help make up for that. We opened a retail pharmacy when the only retail pharmacy in town closed their doors during the pandemic. And we're really trying to meet the community's needs, but it's tough when you have those federal and state programs that really limit you and should be paying their fair share, but aren't.
Really?
Sorry, Doug. Surprise.
I'm trying to stop this. This is the numbers guy who runs the hospital with compassion. Everything he just told you, I can't add to it. That's miserable in trying to run a business. Besides in California, besides in healthcare, you as patients, neighbors and friends, it's difficult on all sides, and we know that. It's difficult to make the system work, and it doesn't really work.
I'm trying to decide whether to go down the rabbit hole or not, but I think fundamentally, all of us are probably going to say something similar. A primary care organization is a little bit different than a hospital because we don't have a lot of voracious capital needs for technology like these folks do. What we have is a group of people that take care of other people. And so our greatest resources are people. And the greatest challenge we have right now is people do what you get rewarded for, right? That's just a fundamental part of human nature. So our reimbursement systems determine our reward systems. And so we get forced to actually do things that may not necessarily be in the best interest of delivering care because of the reimbursement system. And every one of us will have some type of story around that. We have a Byzantine system of reimbursement in America that is not conducive to delivering good care. What we struggle with is people go into medicine these days to take care of people. there's way easier ways to make money in America. You don't go into medicine to make money anymore. And so what we struggle with all the time is the retention and burnout prevention. And our providers, they don't mind taking care of complex patients. That is not it. Natalie captured it. It's all the other stuff that sucks your soul away, right? And until we get back to, and Jennifer talked about being a healer, that's what people want to do. They want to take care of people, right? And make sure that we can actually help promote people's health. Unfortunately, everybody of us on this panel are trying to figure out this crazy system so that they can do that and not have their soul sucked out. And so, and I'll tell you something, the biggest concern I have is burnout, because when a clinician burns out, you don't go to rehab and, get fixed and come back. When somebody burns out clinically, they go off and do something different on the periphery. So our biggest challenge is to prevent burnout in healthcare by everybody. And we do that by really focusing in on what brings people the joy and meaning in their work. So that's my concern, and that's what I spend all my time, is trying to figure out how can I support our people so that they can feel meaning and joy in their work and take away the rest of that stuff.
I think I'm going to turn this back on you guys a little bit, and I'm going to ask a question. How many of you think access to healthcare should be a human right in this country? How many of you want to worry about your child not being able to get an emergency appendectomy because you just lost your job and your insurance was tied to your job? Right? So, I mean, to add to what people have shared, that for myriad complicated reasons, we have decided that healthcare is a business in this country, and we operate it as a business. And a business's primary goal is to make money and stay in business, right? And healthcare's primary goal is to care for people, and in many ways, those are mutually exclusive goals. So as long as we continue to treat healthcare like a business interest, and I'm not knocking for-profit versus nonprofit institutions. This is not any organization or any institution, but as long as we deliver healthcare through a business model, and we stick Band-Aids and patches on that to try and meet humanitarian needs, we're going to be stuck with this incredibly complicated, incredibly complex system where every day when I'm seeing a patient, I have to decide as you come in, am I going to spend the extra 15 minutes talking to you about the crisis that your family is in and where you are, or am I going to desperately try and run you through the 5 quality indicators of care that say whether or not I get reimbursed for this visit. And the conflict of having to make those decisions every day, and then literally waking up at 2:00 in the morning worrying because you realize there was maybe one more thing you could have done for this patient, or maybe one test, or sitting in your office still returning phone calls at 9 or 10 o'clock at night and having patients complain that you're calling them too late, when what you're really thinking is, you understand that I'm calling you this late at night because I'm still working on today's workload this late at night. And it's so understandable, because as a person receiving healthcare, it sucks sometimes to be stuck within the system that we're in. So there are no easy answers to this, but I would say that the pain point really fundamentally is that we won't treat healthcare like a human right in this country, in spite of the fact that I think that that's what we all want for ourselves and our community and our families. So there's my pain point.
All right, Michael, did you hear about the CEO that went to hell? He was there for 2 weeks before he realized he wasn't in his office anymore. So, yeah. I know. My side job is a comedian. So, but I think the pain point that I just to discuss a little bit here, I think everything's just been masterfully discussed, is just that healthcare is incredibly complex. It's not easy. And it's hard to communicate that to people. And when people are frustrated with it, it's like, look, this is healthcare working exactly as we've designed it to be. And that's the unfortunate story. And none of us can really fix that. And that's the other unfortunate bit of the story, right? But we all love what we do. And, regardless of the joke, I love what I do. It is so much fun because I love helping people and I love seeing the positive change that I am able to affect, which is the culture. But can I really change healthcare? Not really. I can't change the payment system, right? I can't change how it's structured throughout the country, but I can make a small positive impact. So I think that's the pain point that I hope people realize is just that reality. It's complex, and what can we really do about it? So.
The question was about what are the points of pain in your organization that you want people to understand? Just a simple, low, chill question.
Yeah. I mean, in my current organization, I'm experiencing the least pain that I've experienced in my medical career. Certainly, there are things, we're very highly regulated by the state and the feds. And so one of the struggles that I have with the clinicians I work with is there's a huge burden of charting requirements to kind of check the boxes for all the regulatory bodies. And I'm watching, despite the fact that our model is really high intensity, low productivity versus having to see someone every 15 minutes, there's still more and more and more time every year that goes by spent on charting. And then that just reduces the number of people you can see per day because, like a lot of people have said, people don't really want to work till 10 o'clock every night. It's not really great for anyone's health to do that. And I actually don't think it's good for patients either to have the person that's trying to make complex decisions along with you be wiped out or burned out. So I guess I would say that for me, that. And then also just a big change I've seen since coming up here is because the way the healthcare is given in every community in our country now, there's a much more division of labor. So whereas when I first came here, I would see my patients in the office and then I'd take care of them in the hospital. And in the hospital, I would run into the specialist and rub shoulders with them and learn things from them and also feel part of a community. In order to meet all the other requirements people are talking about, to see the 30 people a day you're supposed to see in clinic, you can't really go to the hospital anymore. So there's now hospitalists that do that for you. And there's just a lot more division, and that makes it harder to actually provide decent care to people. And I'm really the thing that kind of struck me was that I'm in that 55 or older. I used to be the young kid in town. I see my mentor sitting right over there. When I, came here as a bright young physician, with my kind of deer in the headlights, oh my gosh, how do I do this? Now I'm one of the old ones, and I wouldn't say it was better in the old days, because I think there's a lot of problems also with the way we were trained and some of the kind of abusive practices around. It's better if you work 100 hours a week. It's even better if you work 120 hours a week, and people kind of were proud of that in some ways. I don't think that's great, but I do think the siloed aspect of our healthcare is not serving people well. And probably everyone in this room has experienced that. You're like, do my doctors even talk to each other? We do try, but it's kind of hard. It's hard when everyone's seeing 30 patients a day to do that, and we're not hanging out together as much, so.
I'm 42 and I feel like I'm in getting to that point of feeling old, so thank you. The deer in the headlights. Still feeling idealistic and optimism, though. Okay, so some pain points. I want to touch on really quick before I go to the pain points. You heard it a few times about the charting and everything, and so that is an area that we focus a lot on, and there are tools that we're trying to deploy. So we talked about recruitment strategies, and so this is, there's a lot of talk about AI and how scary it is, but there's also a lot of talk about AI and how beneficial it is. And there's a few tools that we're looking to launch. Some of it's already rolled out within some of the Providence clinics. One is called DAX Copilot. It's actually, it's an AI system that does ambient listening. And so the physician can actually just have a normal human connection and conversation with you. And this thing just listens and puts it into the chart. And that's supposed to save, hopefully will save them time. There's another product that we've launched called Proveria. Something that we haven't really touched on is the number of messages primary care physicians get throughout the day and throughout the night, and they are required to respond within a certain time frame. So if you can imagine what your email inbox looks like, imagine what a physician's looks like. And so there's a new AI that we're rolling out called Proveria, which helps prioritize that for the physician so they don't miss something critical. So there might be something in that message that says, hey, this person might be flagging an emergency versus someone just has a question about their medication. And so that's hopefully going to help them. The last product that's going to be rolling out, it's probably a few more months away. It's called MedPearl, and it's a clinical decision support AI system. So this is another thing that you think about, which you kind of touched on with physicians, is medicine is changing dynamically. I don't even remember the statistic, though, of how much the knowledge base is exponentially growing. And we're expecting physicians to keep all of this in their head and look at everything and know what to do. And then how do they streamline that referral to a specialist? And so this system called MedPearl uses AI to look at certain information that you're putting in about that patient to streamline that referral so that by the time it gets to that specialist or you're making a clinical decision, it helps you ensure that you're looking at the patient the right way and you're getting the right information so you don't end up in front of a specialist and they go, hey, glad to see you. Now we're going to go send you out for your MRI. And you're like, oh my gosh, why? I just waited 3 months to get here. So that's something. The pain points I want to touch on, and I wrote a few things down. You touched on one of them, which is the subspecialization of medicine. I got Dr. Stokes in here. He's a perfect example of this one. So both Dr. Stokes. So generations ago, you had surgeons and specialists that did more. Their training was a little more generalized and broad. And now we're getting a generation of physicians who their scope is narrowing. And there's a lot of value in that, but it also makes it harder and harder because now I need 3 or 4 physicians to do what one used to be able to do. So don't even think about the cost. Just think about your point about how many people are even coming out of medical school to meet that new subspecialization. The other thing we're seeing a lot of is this new generation. So I'm a millennial. We made it. Gen Z. I don't know what's going on with that generation. But that is a new generation of physicians that is coming out into the workforce. And to be completely candid, to your point of quality of life, that matters more to them than anything else. They're a 9 to 5, I'm out the door. That is hard with medicine. And it goes back again to you now need more bodies to do things like cover call at a hospital because healthcare doesn't just stop at 5 p.m. Your outpatient clinic might close the doors, but the hospitals are still running. The other thing I'd like to bring up on is the other pain points for me personally is we're not great at communication. You'd heard, I think, Candy, you mentioned it, that it's complex what we do, and it's hard to talk about it. It's not as simple. I think a lot of times news outlets and other media outlets, they try to, hey, what's the story? Send us a press release. That's hard because it's not as simple as just a quick paragraph. It's something that we would need to probably sit down and really talk about. And I don't know how we do that thoughtfully in a way that's conducive. And then the last thing I'll say that's a pain point is you mentioned it as well, Supervisor Arroyo, which is the workplace violence. The number of care providers that are getting hit, physically abused, spit on, it happens daily. Actually, for our team here, the executive team, we now track all of those events, and we personally call every single one of those caregivers every week, checking in on them. That should not have happened to you. The challenge we're faced with is nothing happens to those individuals. So if you're walking on a street and someone assaults you, and they just punch you in the face, you can call the police or something, and usually charges are pressed. For some reason, we don't have that same support when a caregiver in a hospital is accosted in the middle of an emergency department. And that, to I think Tori's point earlier, it can really become defeating, and those caregivers may start to second guess if they want to continue to be in healthcare. And that makes it hard for us to build those teams.
I've got 3 pain points. One that's maybe a little more specific to my institution, but I think that everyone could empathize as well. And then 2 points that I think have already been spoken, but I'll word it a little differently. One of our pain points is trust. Our population are the local American Indians who, for good reasons, distrust some institutions in healthcare. Unfortunately, we're one of them. We're kind of, primarily staffed by American Indians, but still the distrust is there. And with a lack of trust, that rapport is everything for educating and persuading to make good healthcare decisions. So when we have issues with retention, all of that time that it took to that trust, that relationship is now out the door, and it has to be established. It's putting us behind.
It's just cutting out a little.
I'm on. That sounds on. Yeah. Burnout. I think Candy said it beautifully, or Dr. Stockton. Just want to word it a little bit differently. And this is a personal belief. I don't know if it's supported by data, but I don't think that long hours, hard work, complex patients, all of that is the biggest contributor to burnout. It's working in a system where you're so well trained, so highly educated, yet you don't have the capacity to make the changes to improve the health of your patients. And kind of along those same lines, so I'm a general surgeon. I did not like primary care in medical school. Was never on my radar. And here I am working in primary care, and I have the utmost respect for these healers. I like that. We'll call them healers. One of the largest contributors to burnout in this area is lack of access to specialty care, mental health, and emergency medicine. When we have a lack of those services, all of that falls on primary care. And it's going to fall on them every single time until we have those services bolstered. And then back to the trust. From a patient standpoint, when the system fails you, that falls to the primary care provider. They don't recognize that it's the urologist in UCSF that's backed up 6 months or whatever it is. It's always going to fall to the primary care provider, and they're going to feel that, and they're not going to want to stay in the system. Those are our pain points.
Could I derail for just a minute? I just want to kind of cap onto some of the things that they said. First of all, Jennifer, a healer is how I've always referred to myself internally. I always worry people laughing at me if I say it out loud, so I'm so happy to hear somebody else say it. But I actually talked about it's been referenced a couple times up here. It's been referenced sort of in passing the presentation. And I would like your help in dispelling a myth that I think is really harmful to the narrative that's happening. So I was raised in the medical community here. I grew up with doctors and around doctors, and I am very familiar with the whole we can't recruit doctors because there's not nice enough shopping for their wives here and all of that type of thing, which I think thankfully we're starting to move beyond. And I am not a millennial. I am older than that. So I'm kind of right on the cusp between these two doctors, and I want to speak for the younger doctors who I think kind of unintentionally get this kind of negative narrative around them. So I want to point out that my father's generation of doctors could afford to work 100 hours a week because they got paid a crap ton of money. They got a ton of respect in the community for doing that. And that salary and that lifestyle and housing prices at the time of enabled them to live in houses that were paid for with stay-at-home spouses who were able to raise their children and do all those things. So when we're kind of like, and you'll hear us because I'm old enough that I do it a little bit too, oh, those younger doctors, they just don't want to work like we did. Like, that is not a fair comparison. My father's generation of doctors were not expected to do all the charting that we had to do. They are not expected to do all the additional and ancillary things that current doctors do on top of it. They were not expected by patients to be available to answer phone calls at 2:00 in the morning on a regular basis. And they were not expected to do their own laundry, cook meals, get their kids to school, help with homework, and all of those other things. And I just want to call that out because I'm old enough that I am one of those older doctors, and I get kind of defensive when I hear that. So I'm asking you to kind of help recognize that the younger doctors that you're dealing with, they are people just like you who have life responsibilities and child raising responsibilities and working partners and all of the things that you have and all of the student loans that are keeping all their higher salaries from really manifesting that way in their life. And so I just wanted to call that out because I think it's so important that we recognize it's not that they're lazy. They actually have to do everything. They can't farm out to housekeepers, nannies, and stay-at-home partners.
Thank you for leading so beautifully into our next question. Our next question is, lower compensation is an issue when recruiting physicians to our area. What suggestions do you have on how we can compete with urban areas who can give higher salaries? And take that any direction you want to go with it. And we can start with Seth since you're right by that mic.
We just pay them more money. I mean, that's what we do. I think that it comes down to trying to create a incredible culture, right? So I talked about that. We have to compete with what we're good at. And so if we can create a wonderful place where people want to be, they're going to see that. I try to gauge what our culture is by, I kind of joke around with it, but it's an actual metric that I try to gauge. Do my staff look forward to coming to work? And if they can't answer that with a positive, then we've got a problem. Would they rather, maybe they would rather be at Disneyland, right? Or somewhere else, but is this the next best place? Because if they look forward to that, they're going to look forward to doing their job. And patients are going to see that when we bring in other healers. They're going to see that, and they're going to want to be a part of it, right? They're going to want to be part of that culture. I think that the more urban, higher paying places will struggle to create that kind of culture. And one of the benefits about us being small is that we have the ability to really impact what our culture is. And so I think that's perhaps our niche, you could say.
Allow me to interject for just a second. We are running short on time, so I'd like to note that not everyone has to answer every question moving forward, but I want to allow for everyone to if you'd like to. Okay, go for it.
I'll just echo what Seth shared about culture, because there's a difference between a job and an avocation. And I tell you, most people that go into healthcare, it's an avocation. It's not, you got to pay people a reasonable amount of money, but that's not what the driving force is. It is the culture so that they can feel successful. When I started at Open Door, I told our leadership team, what we want is people to, everybody, not just the providers, everybody to go home at night, feel like they made a positive contribution to their community, and wake up the next morning and do it again. And that's simple, but really complex to do. But you do it by investing in your people and in your culture so that people feel supported. And that's how we recruit, is that we are letting people know that they can actually try to practice their avocation versus just a job.
Yeah, so I said I'd mention the physician. I just got the thumbs up. I can share the story. So she was trying to get to our place early this morning to get to work. Start her first day. She gets pulled over by the highway patrol. She was going a little too fast trying to get there early. And so the patrolman pulls her over, says, "You don't look like you're from the area," sees her car is packed with stuff, and he asks where she's going. And there's two ways the patrolman could have gone with this, and I was thinking, oh no, what did he say about our facility? But he actually said that facility has improved a whole lot in the last 5 or 6 years. I'm not going to give you a ticket. Go ahead. We are glad you're coming to the area, and we were able to have a good experience there. So we appreciate the good experience that our physician had on the way there. Also, we have a struggle in Southern Humboldt because Murder Mountain, the Netflix series, was made. So I tell every physician about that series, and I say, hey, if you go through town, you can see that it's changed a lot. And so I was talking to my daughter coming home from work a week or two ago when we were talking about this and saying, what can we do? And you talked about the perception of the community. And she says, we need to get the public perception to change. And she said, what we should do is have a contest in the county with the college, with the high schools, have it at each of these locations, have a reward, have a prize for the person who can get the most views on something positive from Humboldt County. And then do that multiple times so that the newest things on social media, whether it be TikTok, X, or Facebook or whatever, the newest things that they pull up when they Google our county on YouTube or something, we get the positive out there. And I thought that was a great idea. I think that that's something that we should look to do and put up some money to say, hey, here's $1,000 reward or prize for the one who gets the most views. And it has to be something positive about the county. It can't be something negative about the county. We have a certain individual in Southern Humboldt that has his own page because of the different things that he does every day. And so we don't want that. We want the positive views. And yeah, we're looking at problems with recruiting, and you talked about the notes and everything. We're going to DAX AI, and so one of my people said we got to talk, so I can get some information from you. But we're on the same EMR system, so our EMR systems talk together. That was a struggle before we switched a year and a half ago, and so we're trying to work to better everything in this community. And so, yeah, I really would like to see if we can get some more positive things out there about this community, because I moved here about 10 years ago, and I was wondering if I wanted to take the job or not. I came to help somebody out with help the hospital out with their finances, and the CEO came to me and said, I want you to take my job. I just resigned. And I was like, I'm not sure I want to. But then I got to know the people I was working with. I got to know the area. I enjoyed the area. It was a beautiful area. And so I ended up staying. I've been here it'll be 10 years this summer. And the things you said about who will thrive, all of them but the Doctors Without Borders is me. You wouldn't want me involved in your care. So anyway, but yeah, I think having some things like that show the positive aspects of this community, because there's a lot of them. I take every doctor that comes out to interview. I take out to Shelter Cove. I go to Black Sands Beach. I spend a good day and a half with them, showing them the area, talking about my vision of our healthcare system, so that they get the vision, they understand the culture of our organization. One of our you have the mission, vision, and values. One of our values is positivity, and it's not that you're positive all the time. It's that if you have a problem, come to me with a solution for it. And that you had the problem, so you tell me what I can do to solve your problem. And so we need to get that positivity out there, and we need to address some of the things that are happening in our community that are negative. I mean, the violence in the workplace and all these things. There's so many things going on that are negative. We need to promote the positive.
I just want to add one thing, but now I've lost it because I was talking to you. And what was the question again? Oh yeah, income, culture in urban areas. That's right. Your point about acting as a community in the positive news, that's what it was. I wanted to share this because it hasn't fully been pushed yet. We just started initially talking about it. But this is something that everyone here has been involved with and the chamber is involved with. It is a community. And one of the things that we've talked about, I'm new. You go online, to your point made earlier, and look it up. And I have a 10-year-old son. It was very questionable as to, is this where I want to move? I came up here. Providence was kind enough to allow my family to just live here for 1 week, no interviews, just live. And it made a huge difference. We don't talk about the diversity we have in education, for example, right? We have our private schools, we have our outdoor schools, bilingual schools. It's incredible. You have the university there. We don't talk about that stuff. We don't talk about the Airbnbs going up to Trinidad. We just put all these hotels down in, old off Broadway in downtown Eureka. And so one of the things that we're going to work on is how do we all contribute? What does that look like financially to maybe create some dedicated personnel and staff members that can actually work on optimizing what the web search looks like, at helping connect people that are coming into the community, not just from healthcare, but anyone who's coming in and helping them connect with others in the community, finding their church, finding their hobbies, et cetera. So that is something that is being worked on, and hopefully more to come soon.
Yeah, and I just also want to keep it real that if the finances do matter, I mean, I'm 23 years out of residency and still paying my student loans off. And it's a lot more expensive to buy a house here now than it was 23 years ago. So I think the community has to think about, like, that's an aspect of the health of our community is, doctors, nurses, teachers, firemen, all the people that we need to have a healthy community need to be able to afford to live here, and need to have some way to get their foot in the door. And then the other thing I'd like to plug is being active politically around our airport, because I think a big complaint for a lot of people compared to urban areas is I can't fly out of here without spending $1 zillion or having to take a bunch of flights to get to where I want to go. So even if we just had a couple more flights to other places, maybe north of here, that kind of thing, I think that would go a long way to, like, maybe nudge people a little closer to feeling like this isn't some Lost Island reality show type of place to live. Yeah.
Yeah, I'm sorry, I really need to emphasize that airport comment because the traveling partners, et cetera, that is a topic that comes up routinely. So that was a good one.
Thank you. The airport has come up in almost every conversation, if not every one. So thank you. But that's great to emphasize. Okay, so we are getting to the end of our time. I want to say, I know there are a lot of comments that came in and questions that came in that we didn't have time for. The benefit of having a big, beautiful panel is there's a lot of you, and the downside is that we didn't get to all the questions. However, the Human Resources Department for the County of Humboldt is looking to organize something again in a few months, and I think that some of these questions will feed into that next event and whatever the kind of forming the topic is. And I'm going to ask some closing questions of the audience through Mentimeter again to get another snapshot of additional interests and needs so that this won't be the end of the line. That said, I want to invite you all to do a lightning round of closing comments. And there were questions, just to highlight, questions about, of all the challenges, what are you most motivated to address and how are you doing it? Questions about needs for OBGYN care, contagious disease, pediatrics, lots of different specialties, geriatric care. So there were quite a few we didn't get a chance to go to. So if you have a way to work in something else that you haven't been able to say yet in your closing comments, please feel welcome to, and we'll start. Let's just start with you, and we'll just go down the line.
Okay. I really encourage people to be involved and to know that you matter. Like, every single person in this room can make a difference. try reaching out to people like Natalie and go to Sacramento, go to DC and talk to people about what a rural place like us needs to thrive. It's a pretty hot topic in the country right now. People want to see rural areas do better, including in the healthcare realm. And they love to hear stories. That's what people want to know, is like, what's happening, where my constituents are, and what do they need, and so you have power. I mean, you have power as an individual human, and especially coming together as a group. I mean, it's just so great to see everyone working together to try to make things better for this great community.
She's hard to follow. Should have changed up the dynamic. Closing comments. A few things. So I'm going through what's called mission formation right now, which is where I'm learning the history and the heritage of who we are. And so St. Joseph actually started here over 100 years ago, 1912. I'm sure you guys are all familiar with the story, with the sisters who landed here and they ran everything. And what they did was amazing, and the impact they made was amazing. And those are the shoulders we're standing on. We don't have rural healthcare. I know there's challenges, and I know I'm new, but I have to tell you, we have a level 2 NICU. We have neurosurgeons. We have a trauma program. We do things here. You talked about urology. That means 2 giant pieces of machine equipment that do radiation for cancer. And I don't know if people know that. The focus, though, is our resources are becoming more and more challenging. It's becoming more and more difficult. And so for me personally, for Providence, it's one, looking to partner and to collaborate, because it is undoable for us to simply, as one single organization, focus and solve all the healthcare problems that we're facing. What we're trying to do is say, what are we really good at? What is the highest need? Let's focus on that. Let's prioritize that, and let's be the damn best at that. And then we'll move on to other areas that we can, but we can't do it all at the same time. And so that's where we're looking to collaborate with one another and work as a community so that we can solve those problems together. And we're going to hopefully focus on what we're really good at right now.
And he's complaining about following Jennifer. Yeah, thank you. I think we've all talked a little bit about how our online presence and just looking into Humboldt from outside doesn't look great, and things that we can do to improve that with social media and what have you. I think that we've talked about how the recruitment and retention is a massive community effort with everybody. I think that everyone listening, everyone that this will reach in some way, should play their part in sharing the greatness of our area and sharing within their circle of influence the need that we have for everyone within healthcare, and see what we can do to work to drive people here. I know that there's some degree of cannibalization between organizations where, we're kind of passing around providers, meeting their needs in different ways. But what we need is to bring people from outside the area to our area, sharing how great it is. So all the help would be great.
Yeah, I agree. The collaboration, we need to have it. Seth and I just spent an hour and a half yesterday driving out, seeing the beautiful Murder Mountain area. And so we were talking about how we can collaborate together down in southern Humboldt. We both have clinics. Yes, they compete against each other for patients and that, but we want to do what's best for our region. How can we collaborate? What can we do to bring more federal and state dollars into our community? And yeah, we need to get that positive aspect of our community out there and really see what we can do to bring the professionals to our area that we really need.
Testing. We had our start since 1911. First hospital in Arcata was actually one of the first hospitals in Humboldt County. It was in a home, 4 stories. Upper story had skylights, and it became the surgical suite. and it was run by a doctor and his wife. He sold it to another doctor and their wife, and they had the same home, turned it to a hospital sort of thing. Ultimately, they had an accident and the house burned down. So the community bought a block. It's right there next to HSU. It's now the Children Development Center at HSU. And you'll see the facade of what looks like maybe an old building, but it's an old hospital. It's really beautiful. I'm glad they kept that. That was a 48-bed hospital with an emergency room, very first ICU in Humboldt County, etc. And it was built in 1943. Volunteer labor, volunteer lumber. When you went into the walls, they were very thick redwoods, and back then the firewall was sawdust, redwood sawdust, in a 6x6 or 2x8 walls. You'd fill it with sawdust, and that would be a fire barrier. Had a steam boiler down below in the basement, and it served its purpose till like 1972 when we built Mad River Hospital. I say that because we came in essence, from the neighborhood, from the earth. We came up. The homes around that old hospital were offices for doctors, and they were also homes for doctors. So it was pretty organic. When we opened up, we built in the new ICU, CCU, et cetera. Technology changed. Nice 6-bed ER that's down 11-bed ER. X-ray equipment that is the best in the community just about right now. We have pathologists that live on the community who help us. We can promise that when we do a mammography and there's something to be concerned with, we'll get a result to you within 5 days, one way or another, and we can treat it within 5 days after that. So that's some pledges we have. We like to do the incubator projects. Our short-stay surgery started with 1 bed, now it's 6 beds. Our wound care started by sending a nurse to Texas to do the MD Anderson School of Wound Care. This is at the turn of the century, so to speak, only not to come home because of 9/11. She was stuck there afterwards. Came home, and then that formed our wound care that has hyperbaric chambers and our wound care for home health, which I'm happy to say will be reopening next month. We were the first home health agency. Thank you. We were the first home health agency to provide wound care. And we went from Trinidad to Willow Creek, down to Ferndale and Fortuna. We took on the most of anybody with PT, OT, SP, formed an adult day health care so people can stay out of hospitals, out of institutions. Now we have a license for 100 people. We have like 5 handicap vans. I was the very first driver of a handicap van. When we had 2 participants, and that was what we needed to get opened up, et cetera, I volunteered and became the first driver. We just kind of built it from the ground up. We have a pain center. We are opening or involved very much with the Behavioral Health Crisis Center. That'll be a relief for all the emergency rooms, especially. And we hope to have that in 2 years, going through that process. And I see nothing but blue sky for a lot of things here in Humboldt County, because we are like an island and it is different. We don't have all those outside influences. We can make things work here. And we have, during COVID, this community came together like I've never seen. The public health, the mental health sections of the county. If we all had been working together so hard during COVID, we couldn't have gotten the grant that we got from the state of California, because they were surprised how quickly we coalesced and formed an organization that could be eligible to receive that grant money. There's more, but I'll let it go.
I think what I'd like everybody to think about it, when I came up here to go to school over 40 years ago, I thought this was the most magical place on the planet. And it was just remarkable because of the beauty we have, and then with the university, the intellectual capital and the cornucopia of culture and art that we have here is remarkable. And I always felt like that the potential was unlimited. And I think in a lot of ways that has always been what Humboldt is, right? That beautiful opportunity to work together and do things better. I love Matt's idea about thinking about the positive, because that's really what we have to do. I've noticed that when I got to Open Door, I realized that there was kind of underlying the feeling of scarcity, that we were so worried about not having enough providers, not having enough help, not having enough money. But if you change your mindset to abundance, it really has a really remarkable impact on what you can do. And so, for example, we did 35,000 more visits last year than the year before. So we provided 35,000 more opportunities for people to get healthy in Humboldt. And we now have 40 behavioral health clinicians that work at Open Door because we decided to lean in together. So there's an old expression that says, if you want to go fast, go alone. If you want to go far, go together. And I totally believe that if we continue to lean in together, that we can overcome any of the challenges that we have. And that's what we need to do. And we have to do this as a community. So I want to leave you with that thought.
When I moved back to Humboldt as an adult provider 8 years ago, I would hear people in the airport and stores and other places. And it seemed like it was like a mandatory pastime for locals to try and to talk up how bad things were here. It was really discouraging, actually. And I will say that I want to echo what we said, like, we see what we lack, and I'm not blind to the fact I've had struggles getting my own family the healthcare and behavioral health care that they need in this community. So I'm not pretending that everything is perfect, but they're right. We don't have what is traditionally associated with rural healthcare. We have something that is so much more than that, in spite of the gaps that we do have. And we work with a number of state coalitions all the time where they send in outside experts and consultants to work with us because poor Humboldt, so bad, needs so much help. And the consultants will sit down with us and be like, "You're doing what? Could you give us your papers on that so we can share that with other locations?" Like Humboldt here in our county, our public health departments, our medical departments, our community-based programs, are models that are shaping what is happening in much of the rest of the state. So talk about us that way. Get to know that. Share that with other people. And the good news is that healers, providers, doctors, we're not magical beings that have to be found somewhere and imported from an alternate reality. The things that will make life better for us here are the same things that make life better for everybody else. So when you're moving towards affordable housing, when you're shopping in local businesses, when you're being kind to each other and service providers in the community, whether it's your bank teller or the person that you get coffee from or the medical assistant in your office, when we do those things, we are making this a better place for our future. And we don't have to try and solve this problem by itself. Every time we work to make our community a better place, we work to actually improve our ability to recruit and retain physicians.
So Matt told me, "Hey, you want to go check out my horses?" And I was like, "Yeah, that sounds like fun." And so we're driving along. He's like, "Oh, this is Murder Mountain." And I'm like, "What? Where are we going again?" So it was fun, though. Had a lot of fun. I have a desire to kind of share a personal experience with you. During my military service a long time ago, I was at Fort Knox, Kentucky, and we went into this building that had a large pool in it. And we were told to kind of strip down a bit, and we went up this huge ladder with a diving board that was really high up, and then we were handed a dummy rifle. We were blindfolded, and then we were told to carefully walk to the edge of the diving board and step off. And that was all good, but I didn't know how to swim, so I was a little nervous, and so I carefully walked to the edge of the diving board, and I said a little prayer, "Lord, if this be the end, let it be quick," and mustered all the courage I could, and I stepped off. And I will never forget the feeling I had of falling in that darkness and then splashing into the water and feeling that feeling of being consumed and that weight of being sucked down. I was then surprised as I found that as I struggled in that water, that I surged to the top, and my head came out, and I was able to take a breath. But then the water sucked me back in. I struggled in the water again, and I came back up, and I was able to take a breath. And I cried out, "Help!" And someone yelled, "Take off the blindfold." And I was like, "Oh, that's a good idea." So I pulled it off, and there was a flotation device, and all went well, right? Well, I think that's a great parable of life, right? We, in healthcare is people. It's not a CT scanner, it's not an MRI. It's people. It's people giving care, it's people receiving care. And it's messy, and it's chaotic, and it's frustrating and infuriating. And no matter how hard we work at it, it often seems like we're failing. But in reality, the harder we keep working at it, we keep making progress. And just as I found that surprise, that I was able to keep coming up and getting a breath, even though I kept getting sucked back down in healthcare, it's kind of the same thing. We're able to take a breath, we make some progress, and we keep working at it, and we keep struggling at it, and we get through it. But we have to keep working at it. So as you have frustrations, as you have concerns, those are the things we need to talk about. Those are the things that we can work on. We have to think of reality. We're not going to be able to change the system in the country, but we can make small incremental changes. And so those are the things that we need to approach step by step. So thank you for the time.
Beautiful sound of a mic being jostled. Well, I want to take an opportunity to thank you all. And before we kind of close and do a final round of applause, I also want to say I appreciate that everyone ended with as positive a spin as you could, and some interesting kind of stories about where you've been and where we're going. And I think, from a collaboration standpoint, hopefully it's uplifting to people to hear that you're all working together and there's a regional approach and there's some of these collaboration strategies. And I also want to acknowledge, I feel like I'd be remiss if I didn't acknowledge that a lot of people are tuning in today, are going to watch this footage or are here today because they've had a lot of difficulty. And you all have had a lot of difficulty. In interviewing each of you, I've heard the part that's less rosy. And even sounded, at times sort of like desperate to get your head above water. So I don't want to be cavalier about that, I guess. And I don't think we are. I appreciate that we're, trying to close on a high note. And just want to kind of acknowledge to all of you and to the community that we're hearing a lot of serious challenges for people in our community and where they're just not getting what they need. So I hear that. I'm committed to, continuing the conversation with you all, engaging fellow elected leaders at the local and state level and beyond to really kind of work with us. And so in the spirit of that, there are some closing questions. So I know we're a little over time, but I want to encourage people to stick around just for a couple closing questions with our good old friend Mentimeter and the QR code. But before we do that, I'd like to invite everyone to thank you, and then we're going to do a quick photo off to the side while folks are answering that question. So please don't leave all of you on the stage. So let's please give a round of applause to our panelists for joining us. Thank you. Thank you. And now.